going to shift gears and talk about the management of the small renal mass and really take sort of a whirlwind into the AUA guidelines for this. I sat on the AUA committee for the guidelines committee for this, but also my group. So to do the guidelines, you need a summary of the data. And usually what will happen is a systematic review of the data occurs, like a meta-analysis systematic review. And it's done by different groups. This particular guideline, the AHRQ actually had a grant that sort of formulated the data that would guide the AUA process. And our group sort of did that AHRQ review. And so there's an exhaustive document, which is basically like a book of all the data and the studies that we went through that's commemorated. So for people with like a desire to look at the detail, the book is available if somebody wants to kind of look at the comparative effectiveness and effectiveness of what we're about to talk about. The focus of the guideline was a clinically localized sporadic renal mass or a Bosniak 3 or 4. So like the typical surgical, what we would think is a surgical lesion. And important updates, so the last guideline was in 2009. This guideline came out first in 2017 and then was updated in 2021. And there was no index patients anymore. So there was a focus on individual assessment of the patient, of the tumor, of renal functional outcomes and harms. There was an increased focus on renal functional outcomes as an important variable in decision making, and clear definitions for the role of partial nephrectomy, which honestly is preferred in the guidelines for most of these tumors, but also a role for radical nephrectomy. And then new perspectives on renal mass biopsy, which we talked a little bit about on a couple of days ago. Thermal ablation, of course, plays a big part here, and of course, active surveillance as a true bona fide option for patients with renal masses. The evaluation and counseling is part of the sort of guidelines. Starts with a high quality, multi-phase cross-sectional image. This could be a CT scan or an MRI. Multi-phase because you want to see for enhancement. So you're saying, is this solid? Is this cystic? Is there fat? Could this be an angiomyolipoma? And there's also a call out in the guidelines to assess complexity of the tumor. So there's various complexity scores that have been published. The most common in the United States would be the nephrometry score. And the idea there, the panel felt that if you included that in your assessment, that I would know what kind of patient you're talking about just by the objective measure of the nephrometry, and be able to sort of talk about complications relative to a more complex versus a less complex tumor. Chest imaging and staging was left ambiguous. There was a call out to do it, but the timing and kind of what modality, most people get a chest x-ray for a small renal mass, for example. Assigning a CKD stage is important, and also the degree of proteinuria. And I would go back and say, if a patient has end-stage renal disease or is compromised in renal function, today's MRI gadolinium is safe. So this idea of the nephrogenic systemic fibrosis is non-existent anymore, and you can safely administer gadolinium in those patients. This is the schematic of the guideline, really kind of a busy slide. We talked about sort of the evaluation and diagnosis a little bit, but how do you assign a CKD score? It's based on GFR and the degree of proteinuria. So a dipstick in the office for proteinuria is probably enough, and then based on the creatinine, you can use either the MDRD or the CKD epi formulas to actually calculate a GFR. And so if somebody has a GFR of 70, they would have grade 2 CKD, right? And if they don't have albumin, then it's basically A0. But there are implications to having pre-existing CKD and surgical management versus if you don't have CKD, and I'll show you some data on this. In terms of counseling, of course, a urologist should lead the team, but a multidisciplinary team may be necessary, right? So having access and relationships with all of the stakeholders on the slide is important because they are key stakeholders in the process here. And we should counsel the patient and include perspectives on the tumor biology, patient-specific assessment, including things like sex, the complexity, we talked about the nephrometry score, and histology if there's a biopsy, and of course imaging characteristics. But it's called out that T1A, tumors less than 4 centimeters, generally carry low oncologic risk. This is a forest plot from our systematic review showing that male sex predicts malignancy, so male sex is a risk factor. And this is another forest plot that looks at size, and that too is predictive of malignancy. This one's more intuitive. The bigger the tumor, the more likely it's malignant. And so to put it in perspective, we did this study where if you look at the predicted risk of renal cell carcinoma for a woman with a less than 3 centimeter tumor that's not complex, so low nephrometry, 64%, let's say for a 4 centimeter, 3 centimeter tumor. That same tumor, if you change that scenario to a male with a larger than 3 centimeter tumor and a nephrometry that's more complex, all of a sudden you go up to 90% malignancy. And then if you look at sort of high grade or more aggressive malignancies, there is a disparity related to sex, complexity, as well as size. So it is important and modulates, right, the risk of the tumor when you're discussing this entity. Physicians should review the most common and serious urologic and non-urologic morbidities of treatments and take into account age and comorbidities and life expectancy. And it's important to note that in the small renal mass, especially under 4 centimeters, oncologic outcomes are actually, they're going to be determined by like the tumor size, and a 6 centimeter tumor is going to have a worse oncologic outcome potentially than a 3 centimeter tumor. But because the treatments are so effective, overall survival ends up being related more to comorbidities. And so when you look at thermal ablation patients and you look at overall survival, it'll be lower than partial nephrectomy because we select the healthier patients for partial nephrectomy and they die of other causes. And this is sort of that schematic here, is that cancer-specific survival is excellent. It's stage dependent. T1A does better than T1B, better than T2. And then overall survival is different per modality, but that's usually driven by cardiovascular health, honestly, is kind of the biggest sort of killer of these patients who have sort of risk factors for cardiovascular health. When you look at treatment options, radical nephrectomy, it has the greatest decrease in GFR out of all the modalities you're taking out a kidney. It also has the highest risk of making somebody go to CKD 3, stage 3 or higher. Partial nephrectomy is excellent for preservation of function, but carries a higher risk of blood transfusions and urologic complications, mainly urine leaks in the literature. Thermal ablation carries a higher risk of local recurrence, but if done on the right patient, as I'll show, and sometimes with a second session, can achieve the same outcomes in select patients as partial nephrectomy. And then active surveillance is an area I've done a lot of work on and certainly is an emerging good option for certain patients. So we should look at the importance of renal recovery and talk about the risk of temporary or permanent renal recovery or renal replacement or dialysis. And there is a call out to potentially consider very soft referral to nephrology if one of these things is true. But essentially, if you have somebody with CKD and you think you're going to make them worse during surgery, there's proteinuria, et cetera, it's probably a good idea to get a nephrologist involved, optimizing the situation and working with you to make decisions in these patients. This is an important one. For patients under the age of 46, it is recommended that they get genetic counseling, and this is based on data from the NIH that I'll show. And then we should consider genetic counseling for those who are multifocal, bilateral, or if there's a personal or family history suggestive of Birt-Hogg-Dubé or von Hippel-Lindau, et cetera. And the data for the age, it comes from a paper, a really nice paper by Brian Shook when he was a fellow at the NCI, it published in JCO, that shows an overlap of sort of the age distribution of those with hereditary renal tumors with a sporadic sort of distribution and kind of where they interface. And it is thought that an age of about 46 kind of captures most of the hereditary tumors. Of course, you always have to be on the lookout for these. And an issue emerging is the lack of genetic counselors to be able to sort of counsel these patients. And so who do we refer them to locally, et cetera. But this is a recommendation for genetic counseling for younger patients. Renal mass biopsy, the first day I showed you some performance characteristics essentially should be obtained if it would influence management, if it's going to change what you do. And I did, in the discussion, brought up the study, so I thought I'd just show the slide. These are all patients, and each bar is a renal tumor. Green and blue represent the lower grade portions of these small tumors. Orange and red are the higher grade. And if we sort of take a distribution of these small renal tumors, you'll see that if you biopsied, you may hit a lower grade component. And the only person who died in this cohort is the one with an arrow, which you could see if you biopsied that patient, you'd get a low grade. If you were to get a cancer, it would be a low grade malignancy, but there's a small high grade component. In fact, and this was a lethal tumor. The point is that heterogeneity and grade cannot be discerned accurately on a renal biopsy. What can is if it's cancer, you believe it. If it's not cancer, take it with a grain of salt, because there's a false negative rate of about 15%. There's a non-diagnostic rate of about maybe 10%. And then, of course, there's the grade discrepancy. Renal mass biopsy is safe. A diagnosis of malignancy is highly reliable. And there are some limitations: the non-diagnostic rate, the negative predictive value, grade concordance, as we had just discussed, and then this issue of the oncocytic conundrum, getting oncocytic reads on it, and is it an oncocytoma or is it a renal cell with oncocytic features? And there's a discouraging statement, so we should not really be biopsying or aspirating cystic renal masses. It's generally not advised, so there is some discretion, I think, left there. In terms of surgical management, there are 3 surgical managements: radical nephrectomy, partial nephrectomy, and thermal ablation. And other technologies are investigational at this point in time, so those should not be offered as standard of care. Things like cavitation and microwave. There is a call out to prioritize partial nephrectomy for patients with CT1A renal mass. So this is a stronger statement than prior, with an acknowledgement that partial nephrectomy decreases the risk of detriment in GFR, as shown by this systematic review forest plot. There's strong data suggesting that. And there's also strong data that the incidence of stage 3 CKD, so severe CKD, is also favors partial nephrectomy relative to radical nephrectomy in patients. And we should prioritize nephron sparing. And this gets to the whole absolute indications and relative indications for partial nephrectomy. Anatomic functionally solitary kidneys, those with bilateral tumors, familial syndromes where it's going to come back in multiple places, pre-existing CKD and proteinuria. So nothing really kind of new, I think, there. This is data from Steve Campbell at the Cleveland Clinic, getting to the point of, if someone does not have CKD or proteinuria and they have surgery, their GFR could go down. Let's say they have a radical nephrectomy. Their GFR could come down a little bit, but it sort of stabilizes. Those patients get what we call surgical CKD, and they are a different patient than the patient with pre-existing medical CKD or proteinuria. And you could see the surgical CKD is the sort of darker line, closer to sort of no CKD at all, and the red line are patients with pre-existing CKD and showing sort of a detriment in survival. This is the same idea with proteinuria versus no proteinuria. So actually an assessment of CKD beforehand and understanding where the patient lives, and also proteinuria, is very, very important. In patients who elect partial nephrectomy, we need to prioritize preservation of function. Negative surgical margins should always be the goal, but there is a expert opinion statement on that we should consider tumor enucleation, and I'm not a big enucleator, to be honest, but in certain circumstances, familial syndromes, multifocal disease, or in those with severe CKD, the idea is we want to preserve as much renal parenchyma as possible, and so enucleation is acceptable in those circumstances. And we should avoid prolonged warm ischemia. There's no call out to what that is, and we can discuss it maybe in the critique panel as to what is prolonged ischemia and does ischemia matter, because there's a whole literature on that. My thing would be keep it reasonable. You don't want any ischemia is better than infinite ischemia is sort of, I think, a good thing. But in general, I think we still like to keep it under 30 minutes. But there's data that I think can challenge that. We should consider radical nephrectomy when there's increased oncologic potential, either by tumor size, character, or the renal mass biopsy shows, say, like a type 2 papillary, which is, a very bad kind of cancer, and you don't want to take kind of risk there. And there's some criteria set for radical nephrectomy. Now, interestingly, and the elephant in the room is the only randomized trial that was done between radical nephrectomy and partial nephrectomy. This is EORTC 30904, and this was, an important study of patients with, on average, a 5-centimeter tumor. These were healthy patients with no real pre-existing CKD, so take that kind of there. But it was a randomized trial of radical versus partial nephrectomy, and it showed really no difference in kidney cancer deaths. And there was some worsened GFRs in the radical nephrectomy relative to the partial nephrectomy, but it did not translate to any real demonstrable failure, kidney failure or survival. And so this is the study that is always kind of put forward to say, well, listen, do we ignore level 1 evidence and prioritize partial nephrectomy when the only randomized trial shows no difference? There's some nuance to it. There were healthy patients, and there's some limitations to this study, but it is interesting, and so there's no harm in considering radical nephrectomy in somebody with a higher oncological risk, specifically if they don't have CKD and they're healthy. In patients undergoing surgical excision, there is, for the first time, that minimally invasive approach should be considered, and for a time there. Certainly in 2009, when Andy Novick was in charge of the guidelines, that would have been a very controversial, statement. But there's an acknowledgement now that, minimally invasive is probably a good thing for our patients. And I think we all would agree that, a lap nephrectomy, when feasible, is better than potentially an open. In terms of thermal ablation, I would say that we should consider it as an alternative approach, specifically in tumors less than 3 centimeters. Percutaneous approach is preferable because that saves the morbidity of the general anesthetic. The idea being, if you're going to take someone to the OR and you can cut it out, why not just cut it out and not do ablation? But there is some leeway there. And radiofrequency and cryoablation are both options, and that we should do a renal mass biopsy at the same time. That is recommended. Now, it could be non-diagnostic, but there should be an attempt to do a renal mass biopsy. There is a literature on local persistence or local recurrence in the tumor, but if it's done on a tumor that's appropriate, less than 3 centimeters, and I'd editorialize and say even exophytic when there's no heat sink, that a second ablation session, the literature would suggest, would obtain a negative kind of margin, if you will, and would equal the results of a partial nephrectomy. So I think thermal ablation is a very good option, especially if the patient's not a suitable surgical candidate. Quickly about active surveillance, real quick. There is a statement that for patients with those, especially tumors less than 2 centimeters, it is an option for initial management. And I'd say we've become much more liberal in offering active surveillance. And obviously, it's all about shared decision-making and risk-benefit. We started this project at Hopkins when Phil Perazio, who's now at Penn, was a resident with me. And the idea was to start a prospective study on active surveillance for renal tumors. And of course, now it's like this big registry that's multi-institutional and mature. And what we found is, surprise, surprise, if selected well, the patients have an equivalent cancer-specific survival to performing surgery or intervention. And because we selected the patients well, their overall survival is worse than that of those we sent to intervention. The idea being that if we select patients well, they're dying of other causes, and we've saved them the morbidity of the surgery. And this Kaplan-Meier goes out to 8 years, but we now have data beyond 10 years showing that inappropriately selected patients' active surveillance is a very good and durable strategy. And we do use some triggers for intervention that maybe in the critique panel we can expand on. So future directions discussed was molecular imaging, which was my first or second talk in this conference, biomarkers, decision-making tools, et cetera. But In conclusion, there's a call out to be very individualized in the decision making. There's a renal mass biopsy is an option today. Partial nephrectomy is recommended for the smaller tumors, and then thermal ablation and surveillance have a very good footprint in this space. And thank you, and I list the guideline panel members there.